So I know brachytherapy and CyberKnife is something that's being used in other forms of cancer. Is that something that we use in pancreas cancer? Do you ever see it being used in the future?
We never use brachytherapy for pancreas cancer, even though it's very popular and very, very effective for other types of cancers like prostate cancer or cervical cancer. For pancreatic cancer, it is very difficult to access the area where the tumor is, and it's actually so close to critical structures that any slight 1 millimeter displacement could actually cause a lot of harm. So we actually typically never use brachytherapy for this. So in terms of radiation, there are many acronyms that are out there. It's kind of an alphabet soup, just like with chemotherapy, with IGRT, which is image-guided radiotherapy, IMRT, which is intensity modulated radiation therapy, SBRT, which is stereotactic body radiotherapy, and it goes on and on and on. Basically, there are kind of two flavors of schedules of radiation and two flavors of types of delivery of radiation. The two schedules would be the more traditional type of schedule where we give a little bit of radiation every day of the week in order to add up to a high dose of radiation to the tumor and protect us very close by surrounding normal tissues. And that's the type that we use because we can actually get a better ratio of effect to the tumor compared to the lower effect to the normal tissues to get an overall better outcome, better tumor kill, and much, much safer treatment. There are other types of more abbreviated schedules for radiation. SBRT realm, which is basically a completely different philosophy of giving high doses of radiation either every day of the week for 5 days or kind of twice a week or 3 times a week. The advantage of that is schedule, number one. It's much more convenient for patients, much more convenient for clinics, and it potentially could get patients to systemic therapy faster, and systemic therapy is very important, although that is really only a couple of weeks faster to get to systemic therapy. The other advantage of the SBRT is actually, that's the main advantage of SBRT, kind of convenience for patients and getting patients to systemic therapy faster.
So the former one is the one that we put the fiducials in for?
Fiducials would actually need to be in for anything, and that's the alphabet soup. So the fiducials are for this IGRT. Okay. And the reason that fiducials or markers inside the tumor that you're treating are so important is because during the radiation delivery, we need to be certain that we're actually hitting the right spot. So as we're all sitting here right now breathing, our abdominal organs are moving up and down and kind of slightly forward. And everybody's breathing motion is different. And our breaths from breath to breath are also different. And so as you can imagine, if we were trying to shoot X-ray beams from the outside into a tumor that's deep inside the body, without some sort of image guidance to see inside, we would have no idea what we're shooting at. And that's not advantageous for killing off the tumor, and also it's not safe because there are a lot of normal tissues that are nearby which can easily be damaged by the radiation. So Dr. Anderson here and her team have been great at putting in these what we call fiducial markers, which are basically tiny little markers smaller than a grain of rice right into the tumor, and that allows us to see in real time what we're shooting at with the radiation, so we can ensure that we're covering the tumor with radiation and not shooting, let's say, the intestine, which is just a few millimeters away. It's so crucial.
Yeah, there was a learning curve, as there is with any procedure and any surgery, but we've gotten,
I think
pretty quickly.
I think one point worth making, and maybe not everyone realizes it, but there's a subset of pancreatic cancers, maybe about 15% or so, that really don't metastasize very much at all, but have a tendency to just really wrap around critical blood vessels in the area, so they're unresectable, but they're not really readily spreading elsewhere, and so we really want to focus on local tumor control. And so for these focal, locally unresectable tumors, a combination of chemotherapy and radiation is particularly beneficial. And actually, Mary and her colleagues have been the national champions in figuring out the way to optimally give full doses of chemotherapy and high doses of radiation to exactly that cohort of patients, such that we can have extended survival in some of those patients.
So do you think that that's why, I know our sort of philosophy and stance on radiation is very different from Europe. I just came back from Europe, and like one of the questions they asked me was like, you guys give radiation, why do you do that, right? So why do you think we believe in it? Why are we successful with it?
Right. So I think you've brought up a very, very good point that radiation for pancreatic cancer in many instances is highly controversial. And I think you're right that, and the evidence supports this, that bad radiation is not helpful. In fact, it could very well be harmful. There are multiple analyses of randomized studies that show that patients who did not receive radiation per the protocol guidelines died faster than patients who did receive radiation per protocol guidelines, as is very similar for patients who don't receive chemotherapy as per guidelines. And so even if there is a guideline of treatment out there, we need to make sure that we are really adhering to that guideline and actually even being more specific with image guidance to make sure we're hitting the tumor, certainly. In the olden days of radiation, there was no way to see inside where the tumor was at any given point of time. So people would draw marks on the skin and use other, what we call surrogates, for where the tumor was inside. And several years ago, we published a very kind of splashy paper out there that showed that the pancreas tumor actually moves around. And without accounting for it, the radiation could be off 2 centimeters or more, which means the tumor is here and the radiation is here, hitting the stomach instead. And so that really kind of opened people's eyes to the importance of image guidance.
Since a lot of the tumors are 2 centimeters, so if it's off by 2 centimeters, then
we're not
the whole delivery is somewhere else, right?
Yeah.
So that makes complete sense.
So that's why it's so important to have this great team with us so that we can make sure that if radiation is used, we can be targeting at the right area.
Place, yep.